Welcome to another Puscast, the Persiflager's Puscast, to review the infectious disease literature with commentary for the last 2 weeks of December 2008. I don't know if this is the last podcast of the year, since it covers material in December, or the first podcast of 2009, but either way, I am on the Mayan calendar, so my New Year's begins July 17th, and I believe the end of the world is in 2012, so enjoy your last 3 years. For those of you who are sick of this intro, remember you can skip ahead if you're using an enhanced podcast. This is on iTunes, so if you like this podcast, feed my ravenous ego by writing me a glowing review on iTunes. This is brought to you by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at Pusware.com. All the opinions in this podcast are those of me, Mark Crislip, MD, and Pusware LLC, and nobody else. This is CME accredited, so listen, take the online quiz, and get a half an hour of free CME, thanks to Legacy Health Systems. Because it's CME accredited, I have to mention my conflicts of interest. I have none. Not that my honor and integrity are not for sale. If you would like to advertise on this podcast, say Cialis would be a good choice. I would be more than happy to run a spot for Cialis. Now, I should also mention, because the world needs more Mark Crislip, that I do a Quackcast, a review of supplements, complementary, and alternative medicine, i.e. SCAM. That Quackcast is available on iTunes. I write twice a month on the Science-Based Medicine blog, and my own blog, Rubor, Dolor, Kalor, Tumor, available at Pusware.com. If you happen to be a medical student thinking of internal medicine, don't forget about Legacy Health Systems. If they tolerate me, they'll probably tolerate you. Now, finally, I'm back to the old condenser mic. Evidently, Mr. Welch, or maybe it's Dr. Welch, I cannot tell, did not like the digital microphone. He called it thin and trebly with excessive noise, and the S's hurt my little ears. The title of his email was the pain, make it stop. So I'm back to the less convenient condenser mic. And now, on to the literature. These monoclonal antibodies out there are multiplying like bunny rabbits. There is one called natalizumab, which is a monoclonal against the cellular adhesion molecule alpha-4 integrin. It's used for the treatment of multiple sclerosis and Crohn's disease. The bummer of this particular is that it may predispose you to developing PML. Initially, this was used with combination therapy, and PML was diagnosed in patients on this agent. It had been withdrawn from the market and re-released, and now there is several more cases of PML associated with the use of this monoclonal antibody. All these immune-modifying agents are definitely infectious disease employment acts, although there's currently no therapies for PML. The patient in question had multiple sclerosis and was on this agent for therapy, and it's sort of awful. He was exchanged from one horrible neurologic degenerative disease to another horrible neurologic degenerative disease. An ounce of prevention is worth a pound of cure, or as I've heard elsewhere, an ounce of perversion is worth a pound of pure. Now, the United States government spends $200 million a year on abstinence promotion programs, and these programs are not allowed to give information on birth control or safe sex. What they do is they have the kids take a vow of abstinence. Does it work? Let's see. You got a bunch of ragingly horny teenagers, and you're going to say don't have sex. Turns out it doesn't work. The study, which is published in the Journal of Pediatrics, demonstrated that those who took a virginity pledge were just as likely to have sex as those who did not, but were more likely to get pregnant, and because they were not using safe sex, increased their risks for sexually transmitted diseases. Hence the inclusion in this podcast. I was actually awake for New Year's this year because I had to go pick my son up at a party after midnight. He was insistent it had to be after midnight. I presume he wanted his New Year's kiss. But be that as it may, abstinence vows do not work in prevention of sex. It just makes people sloppy in their birth control and prevention of sexually transmitted diseases. So, Again, risk factors for acquiring STDs are, of course, having sex. And I just mentioned this because I was sort of flabbergasted at the results. They looked at 2,800 patients in an STD clinic that either had chlamydia or gonorrhea and did a survey to find out where they found their partner. It turned out that 23% of men who have sex with men, 2% of women, and 3% of men who have sex with women found their partner on the internet, which boggled my mind. Now, having your partner on the internet was not associated with an increased risk of a sexually transmitted disease in this study, but finding anonymous partners on the web does not strike me as the optimal way to avoid STDs, especially if you've recently taken a vow of abstinence. Herpes and HIV go together like peanut butter and jelly, probably a contraceptive jelly in this particular case. Now, there have been prior studies we have talked about in this podcast on the importance of suppressing herpes to prevent HIV replication. There's a study done in Africa where women who were not on anti-HIV medications were put on anti-herpes medication and had a decrease in their viral loads. This study has now been reproduced in Peru, where women who were co-infected with herpes simplex and HIV were put on valacyclovir. Those that were on the valacyclovir had decreased levels of HIV in both their blood and their cervical secretions. So this has the potential to both slow the progression of HIV and to decrease the transmission of HIV by suppressing herpes. The question in resource-rich countries like, are there any more? I don't know. Whether or not you should have a patient who is suppressed with their HIV on anti-herpes medications for the purpose of slowing down the HIV is not known, but most patients with herpes tend to reactivate it at low levels, as we've talked about in other podcasts. It may not be clinically evident. And so I think it's very reasonable for a patient who has HIV and HSV to have them on an anti-herpes medication as well, even if their viral load is suppressed and they're not having active herpes lesions. I'm sure there are those that would disagree with that. The HPV virus is a cause of cervical cancer, oral cancer, and anal cancer, and can be prevented in women with the HPV vaccine. But where do women get this infection? Could it be, men? Now, it would make sense from a public health point of view that the best way to prevent spread of this disease would not only to vaccinate females, but to vaccinate males as well. Men are less likely to get penile cancer, anal cancer, or oropharyngeal cancer. I'm still not quite certain how genital disease gets to the oropharynx, but be that as it may, men have less disease than women with this particular agent. But it would make sense to give men the vaccine. And a current study in boys showed that a vaccine directed against HPV types 16 and 18 was very well tolerated and generated an excellent antibody response. Now, whether it remains to be seen whether it will prevent cancers in these boys and whether or not it will prevent transmission to their sexual partners. If this vaccine does become available, both my boys are going to get it. Of course, they've taken a vow of sexual abstinence, so I suppose I don't need to worry. It is flu season, and I hope you've had your flu vaccine this year. Now, it turns out that there are 3 strains, as usual, circulating, H1N1, H3N2, both of which are influenza A, and then influenza B. It turns out that the H1N1 strain is resistant to Tamiflu. They tested 50 samples at the CDC, and 49 of them were resistant to oseltamivir or Tamiflu. But curiously, they're still susceptible to the old school drugs of ranitidine, amantadine. And usually, at least in prior years, we've had a lot of amantadine resistance in influenza A, mostly out of China. So Tamiflu cannot be reliably used, i.e. oseltamivir, in patients with influenza, especially in those states where they're having a lot of flu, which is currently Texas, Hawaii, and Massachusetts. This report does not mention amantadine resistance in the other strain of influenza. However, unfortunately, this year the circulating strains are well matched with the influenza vaccine. So your best bet, rather than treat the flu, is to prevent the flu. Plus, as I've said many, many times before, it gives the government a chance to insert those tracking nanobots into your deltoid muscle. I learned a new medical word today. Autochthonous. Autochthonous. It means found in the place of origin. Well, anyway, what does this have to do with ID? This has to do with hepatitis E. Now, hepatitis E has been a big problem in the developing world, where it's a waterborne illness that has a particularly high chance of killing pregnant women. Fortunately, pregnant men are spared. It's also been found in Europe and in Denmark, as we've talked about in other studies. It appears to be associated with pig farmers. This study was done in Germany and looked at a phylogenetic and case control study of hepatitis E infection in Germany. And they found that hepatitis E was associated with consumption of offal. I know it's pronounced offal, but I'd rather pronounce it awful because I don't want to eat the innards of pigs, and the consumption of wild boar, which I guess they still have in Germany. The only wild boar I'm aware of in the United States is Bill O'Reilly. In preparing for this, I did find a smattering of data to suggest that hepatitis E can be found in and around U.S. pigs. Now, the extent of this and whether or not it poses an infectious risk in the U.S., I cannot say. I think it would be wise to do two things. One, don't eat raw pork. Duh. And the other thing is I would suggest not drinking water that pigs have drunk from, or water that's run off from a pig farm. Duh. But one would wonder if hepatitis E is a problem in U.S. swine as well. But the take-home message in my mind is if you have some of the acute hepatitis, take a careful pig exposure history. And if they have been around pigs, you might want to check for hepatitis E. Sounds like a college in northern Ghana. Where do you go to? NGU. NGU, of course, is non-gonococcal urethritis, and it's often due to an organism called Mycoplasma genitalium. What they looked at in this study was relapse and why patients failed therapy. And they found that it was due to the fact that the Mycoplasma genitalium was associated with an induced macrolide resistance. They took the organisms before they got azithromycin and looked at them after they got azithromycin and found out that they became resistant due to mutations in the, you'll love this part, you ready? The V region of the 23SR and A gene. Now, why did they fail? Well, the majority of patients who failed because they had a single dose, 1 gram of azithromycin, instead of, as is recommended in Scandinavia, a 500 milligram dose followed by 250 a day for 5 days. So what is the optimal therapy for non-gonococcal urethritis? Is it a single gram of azithro? Well, you may be breeding resistance if you do that, and it would appear from this study that it's better to give them the old Z-Pack. Boy, wouldn't you think it'd be nice if the makers of Z-Pack would sponsor this podcast? My New Year's resolution is to whore myself out to the pharmaceutical industry, so this is a perfect opportunity. I don't know if this is a clinically helpful study or not, but I'm going to throw it out there. It's from the American Journal of Surgery, and they looked at the clinical findings of necrotizing soft tissue infections. Now, when someone is admitted with the classic signs and symptoms, crepitus, skin necrosis, bullae, gas, hypotension, that's easy. I will pause here to note that if you're waiting for gas to show up to diagnose a soft tissue infection, you might as well get ready for the autopsy, because gas is often a late manifestation of necrotizing fasciitis. However, if you have a necrotizing soft tissue infection that's early, you may not have all those signs or symptoms. And this study looked retrospectively at a small number of patients, 21, to see if they had other signs and symptoms that could help differentiate a normal soft tissue infection from a necrotizing soft tissue infection. They found if the white count was greater than 15,000 or the sodium was lower than 135, they were more likely to have a necrotizing soft tissue infection. Now, I don't know. Not very many patients. Retrospective. I don't know that I'd necessarily hang my hat on the conclusions of this study. But certainly, the sicker the patient, the higher the white count, the more likely the necrotizing infection is present. As you can see, this is kind of a no BFD as far as I can tell study. But if you're worried, you could always use this particular study to help goad your surgeon into taking the patients to the operating room. They don't take care of otitis media in adults. If you got a case with otitis media, it's probably Wagner's granulomatosis and not an infectious disease. This is a Cochrane review. Ooh, Cochrane. Must be good. That looked at whether or not TID, QID amoxicillin was equal to once or twice a day of amoxicillin with or without clavulanate for acute otitis media. Now, I'll just read the conclusion here, which is, this review showed insufficient evidence to judge whether once or twice a day daily doses of amoxicillin with or without clavulanate were comparable with 3 or 4 daily doses for the treatment of acute otitis media. The evidence appears to be biased, and therefore no firm conclusions can be drawn. I'll give you my bias. Now, otitis media is probably a self-limited disease in a lot of kids, but if you're going to give people once-a-day drug, you're really trying to breed resistance. The way you breed resistance is you give a little bit of drug for a long period of time, and what doesn't kill you makes you stronger, to quote Nietzsche, and you get resistance. Big problem with strep pneumo is resistance, and we've seen less of it thanks to the vaccine. But I would anticipate that if the pediatricians are giving a lot of kids once a day amoxicillin, they're breeding resistance in strep pneumo to beat the band. That would be a study that would be of interest. Comparison of resistance rates in kids on once a day versus QID amoxicillin or amoxicillin clavulanate. I can predict the future. It would show more resistance in the once a day group. You're not busy. Why don't you go do that study for me? Now I always hear the voice of Intego Montoya in the back of my head saying something like, I do not think you know what you think you know, if you know what I'm talking about. Anyway, there seems to be the emergence of resistance of Clostridium difficile to metronidazole. Now, I was always taught that you could not develop resistance to metronidazole because resistance mechanisms were fatal to the organism. That was, of course, wrong when you think about it, since resistance is always possible, even if it is difficult. And it turns out that some subtypes of C. difficile have increased MICs to metronidazole. There are several different ribotypes of C. difficile. One of the ribotypes, 001, I like the fact it's 00, it seems to have this license to kill, has increased MICs to metronidazole. And that particular strain, although not the others, upwards of a quarter of strains have MICs to metronidazole of 6 or greater micrograms per mil, which is not surprising to a Darwinist like myself, but still depressing as we lose yet another antibiotic in our armamentarium in the fight against infectious diseases. There is a contingent out there of raw food and raw milk advocates, advocate being a code word for lunatics, who think that if you cook or otherwise pasteurize your food, you're losing some magical properties in it. The problem is that heat kills bacteria, and if you don't apply heat to bacteria and or the products that contain them, you'll get sick. This was shown yet again where there was an outbreak of Campylobacter in people who were eating unpasteurized milk and cheese. Now, this case was not due to raw food advocates, but a, quote, insular religious community, population approximately 150, unquote, from the CDC site, who practice old-style, small-scale, traditional farming techniques. And there's nothing more traditional than getting foodborne illnesses. So again, remember, milk is a good source of bacteria. Have you ever seen a cow poop? It goes right down past the udder. Ugh. Raw milk is basically drinking diluted cow manure. Bon appetit. It's amazing how long-lasting the effects of antibiotics can have on normal flora of the gastrointestinal tract. Now, this study took some volunteers who took 7 days of clindamycin, and then they collected poo specimens over the next 2 years. If you think you have a bad job, how'd you like to be that researcher? They found that Enterococcus colonies were both diminished and the species variation was increased. They found that erythromycin and clindamycin resistance went from about 20% to 70% with a 7-day course of clindamycin, but this resistance lasted up to 9 months after a week of clindamycin. So if you take a drug like clindamycin, not only do you breed resistance rapidly, but those organisms then persist for a very long period of time. And I'm sure that's true with other antibiotics as well. There's old data, which I don't have references for right here, to suggest that all the old school antibiotics, amoxicillin, tetracycline, chloramphenicol, etc., if you take them, you'll get resistant organisms in your stool within 3 days, and they persist for weeks after you take resistant antibiotics. Part of the importance of this is that if you have anybody that's had an antibiotic in the last 6 months and they come in sick, you should avoid that class of antibiotics until you have cultures and susceptibilities back. What is the source of H. pylori? Now, there was a study that showed that maybe humans acquired them from lions back in the days when we were wandering the plains of Africa. But where do the modern humans get their H. pylori from? This study was out of Japan and looked at children with H. pylori and compared them to the strains found in their parents. And they found that the majority of children got their H. pylori from a family member, and that 70% of these had a pattern of DNA that was identical to that found in the mother. A smaller number had both parents, and one had a DNA fingerprint that matched the father's. So at least in Japan, most children who had H. pylori were getting it from mom. See, we have all these issues with our parents, how they raised us, what they do with us. Now you can blame them for your gastritis. It's your fault, Mom, that I turned out the way I did, and I have stomach upset as well. It has long been known that Pseudomonas aeruginosa has a bad effect on patients with cystic fibrosis. They get chronic colonization, inflammation as a result. The Pseudomonas makes proteases that dissolve the lung, and it's overall a bad deal to get Pseudomonas in your lung if you have cystic fibrosis. But that has always been the only disease that has problems with Pseudomonas chronically, or so I thought. But that's why we read the literature, isn't it? To learn new things. And this article was entitled Chronic Pseudomonas aeruginosa Infection in COPD. And it turned out that in a subset of patients, a whopping 13 patients, that they had Pseudomonas aeruginosa isolated, and these organisms over time became increasingly resistant and made proteases, and probably helped make the lung disease worse. The interesting thing is that these patients usually had one Pseudomonas clone that remained in the lung for years, and this organism evolved over time, increasing resistance and other issues that worsened the COPD. So it may be that Pseudomonas aeruginosa causes chronic infections in COPD patients and causes the same problems with infection and inflammation that one sees in cystic fibrosis. Now, in your world, 23 minutes and 35 seconds have gone by. But in my world, I've stopped recording, gone to the mall, and watched the movie Bolt with my youngest. And I tell you, the 3D animation with the new digital 3D effects from Disney are mind-blowing. It was an entertaining movie, but what they can do with 3D animation these days is just incroyable. I'd recommend you take your niece or nephew or your kids or your grandkids off to see the movie just so you can enjoy the mind-boggling 3D. But this is about gargling. Yes, gargling. Did you know, I didn't know this, that the Japanese gargle, and they gargle to prevent upper respiratory tract infections. This is based upon one clinical trial where garglers had fewer upper respiratory tract infections than non-garglers. I keep seeing the word gargle. We have a resident named Garg. Maybe, well, I won't go there. Gargling is with just water, and this study looked at gargling and whether it was a cost-effective way to prevent infections in patients in Japan, and it was. I don't know how it could be cost ineffective since the gargling is with water, so assume it's free unless they have special gargling water in Japan, which also wouldn't surprise me. But in the 60 days follow-up in this study, there was 0.26 episodes per 30 days of upper respiratory tract infections in the control group and 0.17, about a third fewer per 100 patient days in the gargling with water group. Now, they said it was cost-effective and beneficial, but gargling costs money. How would the gargling cost money since it's with water? I love this. They determined the costs of gargling by multiplying the time to complete a single session of gargling, the frequency of gargling in each group, and the mean wage of Japanese workers. Time to complete a single session of gargling, including going to and returning from the washroom, was determined based on 12 individuals who were not participants in the trial, with gargling considered to require an average of 71 seconds. So if you're gargling, they figure it costs about $183 to do this during the time. Oh, I should laugh. This is so funny. Oh, sorry, $105.30 is what it costs to gargle daily for 71 seconds and prevent your infection rates by about a third. So, gargling, the new way to cost-effectively prevent respiratory tract infections. Oh, I don't think I'm going to edit out the laughter in this one. It's just too funny. So, on to the next study before I giggle myself to death. So, back to the ICU. The longer you're in the ICU, the more your normal flora goes away and becomes replaced with gram-negative rods, especially in your mouth and upper gastrointestinal tract. I always tell the residents that the longer you're in the ICU and the sicker you are, the more your mouth becomes your butt. As a result, when you get infections with gram-negative rods, often ICU-related, that are resistant to organisms. You would hypothesize that if you could decrease the gram-negative colonization and perhaps the yeast colonization, that you would prevent infections in patients in the ICU. And indeed, that is the case in a study in the New England Journal of Medicine. It looked at selective oral decontamination or selective GI decontamination in patients in the ICU. So in the selective digestive tract decontamination, patients received a 4-day course of IV cefotaxime and then topical tobramycin, colistin, and amphotericin B in the oral pharynx and the stomach. When they had this done, their overall mortality rate was decreased by 3.5%. If they received selective oral decontamination, which was the same oral antibiotics but no IV cefotaxime, they decreased their mortality by 2.9%. In this study where they used these antibiotics, they did not see an increase in resistance, and they did not see an increase in their C. difficile. However, when it came to emergence of resistance, the study was of too short a time to determine if there'd be a long-term impact on your ICU susceptibility of your gram-negative rods. I don't know. I mean, you can decrease mortality by doing this, and you'll probably get some short-term gain. I still wonder if you get long-term gain in that you might end up breeding resistance, especially if you use a lot of widespread IV cefotaxime. No good deed ever goes unpunished in medicine. Further information that suggests your mouth becomes your butt when you're in the ICU is a study in CID where they took organisms from BALs in patients with ventilator-associated pneumonia and compared them to those found in dental plaque, and found that they were identical. They found that isolates of Staph aureus, Pseudomonas, Acinetobacter, and a variety of enteric species that were found in the plaque of patients were, quote, indistinguishable from isolates recovered from the bronchoalveolar lavage fluid, end quote. So if you're in the ICU and on a ventilator, what eventually grows in your mouth and on your teeth will end up in your lung, causing pneumonia. What is the proper dose of fluconazole for the treatment of cryptococcal meningitis? Trick question. People should be treated with amphotericin. Well, that's my bias. But not all parts of the world have access to amphotericin B, and in resource-poor places like Uganda, they use oral fluconazole. Now, in this study, they looked at the response of high-dose fluconazole with HIV-associated cryptococcal meningitis. What's high dose? 1,200 milligrams a day. They compared 1,200 milligrams a day to 800 milligrams a day and found the 1,200 milligrams a day to be superior to the fluconazole group, and it had no greater amount of side effects. So the 2-week mortality in the 800 a day was 37%, whereas the 2-week mortality in the 1,200 milligrams a day was 22%. At 10 weeks, 60% of patients had died in the 800 milligram group versus 48% in the high-dose fluconazole group. Now, please note that 1,200 milligrams a day of fluconazole still had a 50% almost mortality rate at 10 weeks. And I don't think I've ever had a patient die of cryptococcal meningitis because I always treat them as amphotericin B. And, of course, my population is not the population found in Uganda. But as the United States slides into a second-class economic power, perhaps we will be treating our patients with fluconazole in the future. And so, if so, give them 1,200 milligrams of fluconazole a day. I guess they think differently in the Netherlands than I do. This was an observational study that looked at the impact of the treatment of invasive aspergillus in AML patients with voriconazole. They had 80 patients in the study with either probable or proven infection, and all were started on voriconazole orally if they could tolerate it. They found that the mortality at 12 weeks was 22%, and the overall mortality was 26%. They figured that the invasive aspergillus mortality was approximately 10% in this population. And they conclude that early diagnosis and treatment of invasive aspergillus with oral voriconazole result in acceptable mortality rates. I didn't know 10% death rate was acceptable. I guess in the Netherlands it is. As you probably know, infectious disease doctors have a particular predilection for epidemiology. This particular was a CDC report. A bunch of histoplasmosis patients and travelers returning from El Salvador. A bunch of people went down to El Salvador to help with a church building, and 9 of the people in this group came down with acute histoplasmosis. Histoplasma, of course, is found in the American Midwest, usually the Mississippi River Valley, but it's also found in Mexico and South and Central America. Also, and I did not know this, in Eastern and Southern Europe, and in Eastern Asia, and in Australia. There is a form of histoplasmosis in Africa, but it's a different type than found in this part of the world. The take-home message, though, is that if you're going to El Salvador, don't inhale the dirt because there's histo in it. As you know, I always use the Clinton technique. I don't inhale because I don't enjoy it. Besides, traveling only brings up risks of infection. Take travel to Tanzania, if you would. This group of people went off to Tanzania. 27 people wandered around just one time in some freshwater pond, and a whopping 81% of them came down with acute schistosomiasis. That's pretty impressive infection rate. Otherwise, they had the usual acute hodgepodge of acute schistosomiasis, cough, abdominal pain, diarrhea, fever, myalgia, fatigue, itch, and rash. I think the important thing, though, is a single short exposure to fresh pond water, mean duration 40 minutes, in a group of safari travelers in Tanzania had a high chance of getting schistosomiasis. Stay out of fresh water, don't breathe, don't eat the food. In fact, white travel. Anything any American would ever want can be found at your local mall. So I'm at 33 minutes and 44 seconds. I think I'll end this podcast here because I have some gargling to go do. Now, this has been the Persiflager's Puscast, review of infectious disease literature for the last 2 months of December 2008. Brought to you as always by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked guide to infectious diseases at pusware.com. Now that you've listened to this nonsense, why don't you go get some free CME? Thank you, Legacy Health Systems. Just take the online simple quiz. As always, if you like this podcast, feed my ravenous ego with a glowing review on iTunes. And if you don't want to write me a glowing review, send me some money. Support the podcast and the bandwidth required to put out MP3s. Finally, there's my Quackcast, review of supplements, complementary and alternative medicine, i.e. scams. I write for the Science-Based Medicine blog. And Rubor, Dolor, Calor, Tumor, the infectious disease medicine blog, where you might also learn a few things. The music is by my son when he was 12, improvising on the guitar. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. Thank you. In dictation, Happy New Year, everybody!